Welcome to The Human Code, the podcast where technology meets humanity, and the future is shaped by the leaders and innovators of today. I'm your host, Don Finley, inviting you on a journey through the fascinating world of tech, leadership, and personal growth. Here, we delve into the stories of visionary minds who are not only driving technological advancement, but also embodying the personal journeys and insights that inspire us all. Each episode, we explore the intersections where human ingenuity meets the cutting edge of technology, unpacking the experiences, challenges, and triumphs that define our era. So, whether you're a tech enthusiast, an inspiring entrepreneur, or simply curious about the human narratives behind the digital revolution, you're in the right place. Welcome to The Human Code. Today, we welcome Dr. Timothy Chou, a pioneer in cloud computing, AI-driven healthcare, and business transformation. As the former president of Oracle's cloud computing business and a Stanford lecturer, Timothy has shaped the evolution of enterprise technology. Now he's leading the Pediatric Moonshot, a bold initiative to revolutionize global pediatric care by using AI and real-time data to improve outcomes, lower costs, and reduce healthcare inequalities. In this episode, we dive into the progression of AI in organizations, from automation to real-time decision-making, why AI must move to the data, not the other way around, and how this shift is transforming healthcare, how AI can address pediatric healthcare shortages and improve global access to care. Timothy's vision is both daunting and doable, and today we're exploring how AI is shaping the future of medicine and decision-making. Let's get started on The Human Code. I am here with my new favorite friend, Timothy Chou. I truly got to say, we've had such a fun time on the pre-show talk that I'm excited to hear what you have to say. You've got a lot of inspiration in you, and there's a lot of beautiful things that you've got going on in this world. So really appreciate having you here. And then again, I just got to ask you, what got you interested in the intersection of humanity and technology?
I think it happened. I started a class at Stanford on cloud computing many years ago. And I always do, in my class, I do the first and last lecture, and in between I have guest lecturers who are all CEOs of public companies. In my last lecture, I end with one phrase, and I say, to those who much is given, much is expected. Not that I quote the Bible that often, but I wanted to get across to them. I mean, I'm sitting in front of 150 Stanford kids who, yes, much has been given. I mean, the fact that they're even there is much has been given. And that they have a responsibility to do something with that is what I wanted to leave them with. And so that's how I end a lecture, like, I don't know, for 10, 15 years. One day I'm sitting there going, okay, what about you? And as you heard in our pre-meeting, I had a very interesting student show up in class one year who had an MD, an MPH, an MBA. He's chief of pediatric cardiology at the Children's Hospital of Orange County. And Dr. Chang, Anthony, he kind of adopted me. And I learned things like, oh, wow, they're still using CD-ROMs? Are you kidding me? And I know you spent time in the world of AI. If we're going to build, trustworthy AI applications in healthcare with particular focus in imaging, the only way we can do this is we have to be able to take large amounts of training data. So that's why right around the pandemic occurring, I'm sitting around thinking, oh, watch Netflix all day or do something useful, maybe, remembering what I say to the students.
Yep.
And so I grabbed a group of, we were talking about friends who are multi-talented in engineering, marketing, et cetera. And we set ourselves a mission. And our mission is to reduce healthcare inequity, lower cost, improve outcomes for children locally, rurally, and globally. How are we going to do that? By creating real-time, privacy-preserving AI applications based on access to data in all 1 million healthcare machines in all 500 children's hospitals in the world. And I say to people, I call it my last great project. It's really a combination of people I know, technology I understand, and a mission which I think is not one you would take on if you wanted to be an entrepreneur that makes a lot of money in 5 years, but it's one that gives the answer to the question I ask the students too much. I have been given a lot. This is my answer to the question.
And I'm calculating the number of miracles that have to happen in order for your moonshot to go. And it's kind of high.
Amen.
And like typical startup investing, you look for a startup that has maybe one miracle that needs to occur. Like if you have too many, you know how difficult of a challenge is. But the vision that you offer is so endearing, and everybody can see how tangibly the world would be better if that was the case, that I imagine that you're attracting some very significant minds to be a part of this mission as well. And so like, how has that journey been for you as far as, sharing this with the world and you and Dr. Chang building this pediatric moonshot?
Yeah, it is. I mean, you said it's daunting, but I also felt like it was doable. I mean, it's daunting, but it's doable.
Well, yeah, because
yeah,
inference, you have training and then you have inference. And so federated training was something that like TensorFlow has had in it for years. So like there is research that goes on how to do this. Technologically, like that is achievable. And then inference, you can distribute that as well. But then there's the legal framework of getting new technology into organizations that are still using CD-ROMs.
Tell me about it.
Yeah, that's scary.
Well, as you already alluded to, we took a step back and went, well, in order to accomplish the mission, we need to build a new rocket, which happened in the original moonshot. And as many of your listeners know, the current approach to building AI applications is really to centralize all the data, suck it all into one giant computing system, learn on it right in the cloud. And we said that can't work in healthcare and life sciences. The data sizes are much larger. Ultrasounds are a terabyte. The security requirements much stricter. Privacy law much tougher. Norway saying we don't want Norwegian data leaving Norway. So we kind of came to the conclusion that in essence, rather than move the data to the application, why don't we move the application to the data?
Yeah.
And so we have built a distributed AI cloud infrastructure for healthcare and life sciences, which literally puts the cloud server inside the building at Children's Hospital of Orange County, or inside the building of a clinic, or inside the ambulance. Because remember, I said we wanted to build real-time systems.
Yeah.
I mean, I know there's a lot of reasons to do, after the fact analytics, but that's kind of like why. I mean, just to give you a little statistic, in the United States today, 60% of the rural counties have zero pediatric expertise. Zero. There are only 3,000 pediatric cardiologists in the United States. By the way, they live in Philadelphia. They live in Chicago. They live in San Francisco. You go to Salinas in California, up to Willits in Northern California, there's nobody there. That's America. You go to India, there's 300 pediatric cardiologists. You go to Africa, in Rwanda, there's one guy. So if you take a step back and you go, well, okay, we're going to go build tons of medical schools everywhere and train everybody. I mean, the quote, American system of medicine, how can this scale? There's no way it can scale. You can't if I'm a fresh graduate from Stanford Medicine in pediatric cardiology, you want me to move to the middle of Montana and earn $1.98? I mean, why would I do that? And you just see that we could build, I think some people, because AI, we try to put it in competition with our smartest people. That's how we want to think about it. It's going to be better than the world's best cardiologist or oncologist or whatever. And I'm kind of going, I don't think that's the point of the whole thing. What if we could build, I call them red, green, yellow applications.
Okay.
Red, this kid needs to be medevaced out of here, right? Or this accident victim, right, has a traumatic brain injury, needs to go to the ER. Red. Green, hey, everything's cool. Yellow, we need somebody else to take a look at this. If we could do that, we could put the brains, in essence, of the world's best oncologists, orthopedics, or et cetera, right, into the rural community, into India, into Africa, right? And so it's not, I always say to people, if your mom works for Google and you live in Palo Alto, yeah, what we're working on is kind of cool and interesting. That's not the point of the whole thing. I really think that's why AI in healthcare both is necessary, but also we're capable of doing that.
Absolutely. And so basically, I think your first kind of iteration of this, or like what you're talking is like in the simplest level of the triage of basically saying like, hey, what is going on here? What do we need to do? And how do we pair the AI with the team on site to basically know, hey, here's the situation and here's how quickly we need to act.
Well, also, if you look at it, I think ultimately all diseases are going to be classified as rare diseases. It's just we don't know enough
That's it. Yeah. Okay.
do that yet, right? Let me just give you an example. There's a condition called focal cortical dysplasia, which is actually a brain lesion. If this lesion is left untreated, a kid has epileptic seizures. So there's a kid in Florida who's had epileptic seizures 2 to 3 times a day. At night, he wakes up screaming for 12 years. I mean, think about that.
Ooh, okay.
They MRI imaged him early on, didn't see anything, started taking him down a treatment of drugs, some they could afford, some they couldn't afford. Ultimately, they were starting to talk about, let's go put in electrodes into his brain. They finally re-MRI imaged him. They now believe that he has this condition. And I actually have photos or images, MRI images that I could show you. I mean, you and I would look at it and go, what's the difference between A and B? No, I can't see anything. But, if you can find it, you can actually surgically remove it. And if you surgically remove it, the kid's cured for life. Amazing, right? Okay. There's a good news and bad news story here. The good news is there's only 25,000 cases of this a year in the US. Good news, right?
Okay.
Bad news, no one pediatric neuro-oncologist ever sees enough of this to be able to recognize it.
Exactly. Yeah.
Right. Now, on the other hand, we all know over in the world of AI that, damn, if I could get all the MRI images of all the kids in the world, I could build a focal cortical dysplasia diagnostic all day and all night. And you can I think you could repeat thinking about the world this way over and over and over again. It's not, we will end up, like I said, I think all diseases will end up being rare diseases. It's just we don't know enough yet.
That is probably it's a very profound statement to say that like all diseases are rare diseases. And I think that is the path that we're going down, which gets me thinking about like, what does that world look like after that fact? How do you see your work impacting the healthcare space? What is the future state that you want to have as far as the experience of people going through this?
Well, I think, there's better people to comment on the healthcare system, which I'll comment is totally broken. But I think we all have to get to, and this technology is part of it, is how do we invest earlier? Earlier meaning, we all invest in the last 10 years of your life, we invest infinite amounts of money, which are in essence the end of productivity for that individual. We do not invest early where making a difference in a 10-year-old kid's life, he has 80 years, 90 years of productivity in front of him. We say kids are our future. We don't spend that way at all. You want to go do a startup in pediatric healthcare? Are you crazy? Why would you ever do that? There's not enough market. I mean, but we say kids are our future, right?
Yes.
So we need to invest earlier from the standpoint of, well, we'll call it the population, but also why are we not investing? Why do we wait until just using this kid? We're waiting for 12 years to figure out what's really going on here. That's how the whole system's built. We're built for the acute issue that happens, which either you're going to go take a drug for it or get surgery for it. That's how the whole thing's built. Why are we not detecting issues way earlier in the cycle? We can. The technology is capable of doing that and beginning to alter what is the other half of this, which is lifestyle. There's a condition in kids. This is a kind of a other type of story. Kids that have cancer, good news, they are given, chemotherapy, et cetera. Their cancer is cured.
Okay.
Bad news, there is a tendency that what ends up happening is it affects their heart. And so while they survive the cancer, they die of heart disease. Now, if you can detect this earlier, the beginning of this, there's all sorts of, back to diet, exercise, all these sorts of things that will prevent this from happening if you knew earlier in the cycle until, right? So I'm just saying, I think the earlier we can know, the earlier we work on these problems, fundamentally, the lower the cost of the system, fundamentally, the better the outcomes in the system. And if we can use technology to do this, where, I was at JPM yesterday, I was like, the beauty, a lot of people work on medical devices and pharma. I said, the beauty of software is, in essence, the cost to build it is zero and the cost to deliver it is zero. I said, the impact the software can have is huge because I don't have the cost of distribution. Or my cost of distribution is very low, right?
Yes.
And I think that's where hopefully, maybe not in my lifetime, but hopefully we all get here where we can do that sort of thing. Focus earlier in the cycle.
There's so many things you touched on. I know we didn't touch on this earlier, but I'm a big mental health advocate. And so one of the things that I'm supporting is the MAPS Institution, they're running the trials for MDMA to treat PTSD and severe depression.
Uh-huh.
And so one of the challenges that they've come to in their phase 3 trials, which they just in the last few months got rejected by the FDA. 2 problems with MDMA. One is you can definitely tell when you've had it. So it's really hard to do a double blind study with the patient.
Right.
The second thing is that treatment is necessary to go along with the substance. And so the FDA doesn't approve treatments, they approve drugs. And they can't approve a drug that requires a treatment that goes along with it. The efficacy of it has to stand alone.
Right.
And so our entire system MAPS is showing basically after I think 5 years, they're showing an 85% effectiveness of the treatments of a 6-month treatment protocol. And so they're showing less than 20% are going back to depression or having signs of PTSD. And yet at the same time, our system that is in place is really supportive of, is it a drug or is it a medical device? And if it's a medical device, is it similar to something that is, old, or if it's completely new, that's an entirely different process. But we have patterns and systems that are set to basically treat symptoms instead of getting to that early upfront kind of approach. And I know that we talked about triage of somebody who is, has a trauma, head wound, they need to be medevaced out. How do you see the pediatric moonshot playing in that space of prevention or early kind of lifestyle diagnostics?
If people are interested, we're actually tracking 140 different deep learning imaging applications in adult and pediatric medicine. You will not be surprised. This is at appcommons.bevelcloud.io, and I know you can add it into show notes. You will not be surprised. There's just a handful of work in pediatrics. And let me just, if the listener doesn't really realize this, pediatric cardiology and adult cardiology basically don't have much similarity. The phrase that's used in the world of pediatrics is children are not little adults. Because, and this is the rationale, is the things that cause mortality and cause issues in kids, which are unresolved, they die. So the population of us old people who are smoking and drinking too much or whatever, the pathologies that we create are very different than what happens in children.
True.
Right. So number one, I think it's just, let's go pay. In fact, I just spent time with the head of neonatology at Stanford. There's a condition in a premature baby where, this is interesting, a chemical gets activated in a baby, normal babies gets activated, which in essence causes the lung to inflate. And he used a great example. He says, when you blow up a balloon, the very first puff, you really have to force it to open up. That's exact because the baby's been underwater. That exact mechanism has to happen when a baby's born. A premature baby, it doesn't happen in a lot of cases. But at this point, they actually know this, and they have an artificial, synthetic, whatever drug that causes this to happen.
Ah, okay.
So, I mean, that's just another example of that never happens in adult.
I don't know, Tiffany, you never woken up and been like, oh, I got to breathe now?
Yeah, I got to breathe. Never breathe.
Gotta start my day breathing.
Yeah, and I think challenge in pediatrics is, I mean, good news. Most kids are healthy. I mean, that's the good news. So all of us, our perception is kids are healthy but the reality is there's a lot. I'll touch on another one. I've spent time with the head of rare diseases at UPMC. And in that usage of the word, rare disease is super rare. And so he's been doing a lot of work in genetics. And so he told me, he said, a couple of years ago, he gets called into the adult hospital. There are 3 patients who are in intensive care. They cannot figure out what's going on. He goes and genetic tests them and comes back with actually 4 diagnostics, which were pediatric rare diseases, which had been undiscovered in the adult world.
Oh.
So that, we, the greater we, right? We say, children are our future. I mean, in 100 ways, that's true. And so I always say to people, if you're interested in what we're working on, we have tons of ways to get you involved. But the more important thing is, let's put some attention on this as a society. And by the way, not only healthcare, but education fit into this category as well. That's the seed corn. It's, one of the reasons I like teaching is, if you can, I like to say I have the opportunity to shape young minds. It's a responsibility and a blessing at the same time, right?
I look at it as kind of like, you're tending a garden, right? Like you want the flower to bloom in its own way, but at the same time, you're there to support that growth.
Yeah. And we're starting to work over in oncology and adult oncology. What we're talking about transcends, all the work we're doing. I always say to people, our computers actually have no idea if they're in a children's hospital or a clinic or an adult. They don't know, really.
Yeah.
For those of your listeners who have had, cancer, one of the things that happens in more complex cancer cases is that they convene what is called a tumor board. So because cancer has this multifaceted side to it, like, well, I need a pathologist that looks at the slides. I need a radiologist that looks at, the lung images. I need a radiation oncologist who knows how to irradiate that. I need a medical oncologist who knows the incredible number of drugs that are now being developed, which are basically, you call it gene specific. Okay. At the big fancy institutions like Stanford over here, or you go to Dana-Farber, they have all these experts and they literally, this is, kind of fascinating. They literally go into a room. It's like a meeting room with PowerPoint. And in a 1 hour period or 1 or 2 hour period, they will give every patient 5 minutes, these complex patients.
Okay.
Present the case, et cetera, and then have this conversation. Now, you look at that, first of all, that only happens at the fancy places. You go get cancer in, Western Montana or whatever. What tumor board?
Yeah.
But yet, and I know you guys have been working in the multi-agent world. If you sit down and think about it, couldn't you build a multi-agent tumor board?
Absolutely.
Right? You have an expert in the image. You have an expert in the pathology, you have an expert in, and at this stage, we're also spending time over in the drug trial world. You look at it, I mean, there's so many different drugs coming out. How does a oncologist, even a general oncologist in the middle of the country know? It's not their full-time job, the whole range of what's available right now. You can't.
And that's the thing. The amount of research that's getting released on a daily basis is more than you can read in a month.
Yeah.
And then to do the job that you're doing, there's no way for anybody in that profession to keep up with where they're at. Plus, if you have a tumor board, any collection of humans kind of has like the dynamics of a human relationship. And so you've seen this study, or you've heard this, I think it was a study about judges, as far as if you have your sentencing before lunch, you're done, right? Yeah. But if you're there after they eat, you're going to get a lighter sentence, right? And I think that we'd see the same sort of results in any sort of dynamic when it comes to like an oncology or a tumor board. I love that name, by the way. So,
by the way, just to make a comment, tumor boards are volunteer efforts. The docs do not get compensated for this. I mean, it's back to this fundamental, we have a broken system. That's another example.
Another example of like how broken the system is. Now, Are there other countries that you see doing this like better that we could gain inspiration from?
Well, just to make a point of it, I think we're all on the bleeding edge of what AI in healthcare. And when I use the term, I think a lot of people, the word software and the word AI are interchangeable. Software could do a lot of cool stuff. I've been in the business for a lot of years. But if we're talking about deep learning, neural networks, et cetera, we're really still at day 1, day 2 of this whole thing, right? Of which ChatGPT exposed us all to the potential of it. And that's really text data, imaging data. We're, we're first minute or something. So I think to tell you there is work, we're tracking work and spending time with folks in the UK that are working in this area, folks in Germany that are working in this area. So there are other places, particularly when you talk about distributed learning and swarm learning, federated learning. There are other places, and particularly, Europe, because of their, I'll call it, more strict way of viewing data. They're much more aggressive about working on how do you build out distributed capabilities rather than centralizing it at Mother Google or whatever. So, there are, but we're all early, very early. There's this unique combination of domain expertise in cardiology, orthopedics, or whatever, and an understanding of being able to build a team. Like I said, we're tracking 140 of these, where I've got some guy who knows what a convolutional neural network is, right? And putting those two pieces together is non-trivial. But I think we're in the early days. I always tell people I was kind of there at we'll call it the birth of cloud computing. Really, even AWS is 15 years old. Salesforce is 20 years old, 25 years old. But even with cloud computing, whether application or infrastructure, we're still nowhere. Plenty of people are running on-prem traditional software models. Plenty. Plenty of computers are being sold that are put in data centers. It's not like it's all, quote, game, set, match, done. So when you look at where we are with AI, I'm kind of like, we're year 1 of a 15-year cycle. Super early.
Oh, absolutely agree with you. And I think we end up in situations where we go from distributed computing to centralized computing. And we find we go back and forth. And it's kind of like, even in the software world, we go waterfall to agile, back and forth as well. Mm-hmm. The pendulum swings, we create new things, and it's cool. And I think we're in their phase of artificial intelligence being centralized, but people like you and the work you're doing to decentralize this and showcase that it is possible to build private systems that can actually help you and support you. Yeah. And I think that's a really awesome push for what you're doing. And we look at even on the social media side, right? Like centralized AI in social media has meant that we are now the product in which our emotional engagement is what the AI is gaining or trying to gain from us. But what I like to see is now let's have AI that is looking at like, what is your purpose? What is your goals? And then helping you to achieve those. And I think that, what you're working on as well fits into that paradigm of giving more control and access to the people where they need it. If, myself and the audience included had a magic wand to help you get to the next evolution of your pediatric moonshot, what could we provide to you?
I think there's multiple levels. At one level, it's really, and you're helping do this, is let's keep telling the story. I tell people it took 40,000 people to get to the moon. We're a few shy of that. So spreading the word, number one. Number two, I think for those people who can engage, do engage, meaning, what does it mean to build a congenital heart disease AI algorithm? I mean, if you're in the space of either the world of cardiology or the world of AI, go start looking at these problems. There's tons of, I said, we already have examples. I mean, let me say how specific this can get. There is a team at Duke working on AI analysis of weight-bearing, low-power CT imaging of the ankle and foot. So normally, right, if you think about it, you go take an X-ray of your foot, there's no load on it.
Okay.
And it's obviously there's information when you can get weight-bearing. But obviously, if you go do that, you can't be subjecting it to a ton of radiation. Hence, low-power CT. So I'm just using that as an example of how specialized this can get. Low-power CT, weight-bearing ankle and foot.
Yeah.
So that.
Okay.
I think we're in the middle of building a distributed AI laboratory for healthcare and life sciences. What do I mean by that? We are going to have 32 sites where all the imaging data is available in real time. CT, low power CT, ultrasound, X-ray, MRI, et cetera. All offline data available from the PACSs, which for the listener doesn't know, is in essence the repository that the radiologist uses to look at the images. And then all the EMR data available to authorized applications. And we want to perfect the art and science of taking research work, whether that's at University of London or in Germany or in Philadelphia, this small research team, and move it from, we like to say, from the research bench to the bedside by implementing it in a laboratory that sees 2,000 terabytes of data a year. We'll have 3,000 servers in it, right? If we can figure this out, we now have a path to take brilliance in low power CT for ankle and foot, and now deploy it across all low power CT systems in the world. So we're in the middle of that. I've been funding all of our efforts to date. This next step is not going to be able to be done that way.
Okay.
So we are actively in conversations with a lot of people who I will say are interested in how distributed AI will work. And I'll just make a comment. If everything moves to, I just pick on Mother Google. If everything moves to Mother Google, well, they build their own chips. They don't buy servers from anybody. So there are a large constituency that is interested in how does a distributed world work. And we're very eager to have conversations with anybody in that space, whether that's from the tech front or the other major area we're spending time in is our new friends in biopharma, where, this is why I said we're spending a lot of time in, clinical trial work, where today the ability to do very precise connection of the patients to the trial is done today. I'll call it haphazard manual. Do you know the right people is the general mechanism. So what we're right in the middle of building is a application. We call it Total Recall, which is connected. Remember, we have a distributed computer sitting inside the firewall so it can talk to the EMR. So now I can take I'll pick on oncology. I can take an oncology patient who has a 3,500 page PDF document as her electronic medical record. I can RAG train a local LLM. And now I can ask questions like, well, what's the difference between the last two CT scans? Or how many courses of cisplatin has the patient been given? What was the reaction? What we learned, we shared this with 12 oncology nurses around the country. And they were like, I told the team, I said, if we had a buy now button, I'm pretty sure they would have hit it. Because we didn't realize how much manual labor they go through, in essence, with a little search bar looking at a giant PDF document. And it's like crazy, right? So we actually, the reason we called it Total Recall is we demoed it to these oncology nurses. Then we turned over the controls to them to let them ask whatever the hell they wanted to ask. At some point in time, one of them said, well, what is the prognosis for this patient? And you're going, this is where AI appears like magic, right? So it does all other stuff, so it must be able to answer that. Like, not you, humans can't even answer that question. So we asked them, so that's why we said, no, it's called Total Recall. It has perfect recall of what has happened with the patient in the past, right? That's what it does. Perfect recall, right?
Perfect recall. That's it. So
that's what it does. Doesn't
right in the name. It doesn't, it's not pontificating on what is actually like going on. It's not connecting the dots, but it's just total recall. Exactly. I love that.
Now, remember, the application now has complete profile information of the patient because it's looking at the EMR record. So what we have come to learn is that in phase 2, phase 3 drug trials, the real data about what those protocols are sitting inside protocol documents that can be 300 pages of PDF. They're sitting behind the firewall because the pharma company doesn't want to let everybody know what they're working on. Okay, if you have a distributed infrastructure, I park a server inside Roche, Bristol Myers Squibb, whatever, LLM, RAG, the protocol document. And now, multi-agent, I can have the total recall agent talk to the protocol agent. And now the hit rate has got to skyrocket because you have now complete knowledge of the patient and complete knowledge of the protocol. And just this is not that hard to do.
No, and that's really entirely, you're talking about things that we do in other areas, right? Like there are applications of this. And in fact, we have RAG solutions running in our own systems. We distribute it for our clients, right? Like all that question and answer stuff is relatively, I mean, it's not a solve problem, but they are solvable. Yeah. They require a little, it's like the early days of Oracle, right? Like, it was a database company, but they were still like building, and like RAG solutions are context based for the most part. You got to figure out how to get the information in a way that the machine can process it. But at the same time, like you're talking about stuff that is, day one implementable, not 2 years, 5 years down the line.
No,
I love it. So I'm going to wrap this up.
Okay.
Is there any other like last bits of wisdom that you would like to share with the audience, of like any life lessons as far as how to live in this, future AI world that we're talking about?
Well, it's something I said to you during the pre-meeting. When I start out my Stanford class, I always say to the students, I go, the quality of a student is not measured by what you know, but by the quality of the questions you ask. And maybe in a world of LLMs, it is even more true.
Yes.
It's the quality of the questions you ask. And I think the more we're able to be curious, the more we're able to ask the right questions, the faster this is all going to happen, right?
I absolutely love it. Curiosity is one of the things that drives this world. And Timothy, thank you so much for being on the show today. Like, I really appreciate the time we've had together.
And I have as well, Don. It's been a lot of fun.
Absolutely. Thank you for tuning into The Human Code, sponsored by Findustries. where we harness AI to elevate your business. By improving operational efficiency and accelerating growth, we turn opportunities into reality. Let Findustries be your guide to AI mastery, making success inevitable. Explore how at findustries.co.